Okay, good afternoon, everybody. I apologize for the video. My organization doesn't allow certain things to be downloaded. So I hope everybody is staying safe and well in all of this as our COVID cases continue to grow. Just want to extend a welcome. No specific updates in terms of the council currently. Just a little housekeeping that I do have to do and just move that the items on the meeting agenda do constitute essential business of the council. Meeting electronically is necessary to protect the health and safety and welfare of Tennesseans considering COVID-19 outbreak and any rule conflicting with the governor's executive order 16 and 34 permitting electronic meetings be suspended. So just want to put that out there. We're going to do a roll call vote as well for who is on the meeting. Claire, if you want to just jump in and introduce and provide any updates if you have any before we do that, we can do that right now if you're ready. If not, we'll go ahead with the roll call vote.
I can go ahead with the roll call.
Okay. I'm trying to see who we have on here.
Can you hear me?
Yes, we can hear you. Go ahead.
Okay, great. Just that to make sure you can hear me. Yeah, I can hear you clearly. Sorry.
Julie, do you need a verbal of everybody that's on here?
So all of the council members, I can read them and just if you can hear and yes that you agree to continue as an electronic meeting. I think so. Dr. Bullock made the motion, and Claire, could you just second it?
Oh, sure. I second the motion.
Thank you. And then I guess through the roll call, if you had any updates you wanted to provide. Next, I'll just go alphabetically. First name Brady.
I agree.
Brian.
Yes, agreed.
Reverend Sanders.
Yes, agreed.
Rajiv.
Yes, agreed.
Dr. Kelly.
Agreed.
And Councilmember.
Yes, I'm here.
That's everyone.
Okay. All right. If that's all we need to do there, I will go ahead and move on. Next agenda item, which is approval of the minutes from our May 21st meeting. Looks like we just barely have a quorum. So if anyone needs a minute to look over the minutes, we can in a moment. But let us know if anyone has amendments. No amendments? Okay. Moving because we lost a few minutes at the beginning. So would someone like to make a motion to approve?
I move that we accept the minutes as presented.
I second that motion.
All right, motion passes. All right. So, all in favor?
Aye.
Aye.
Raise your hand.
Aye.
All right, so we'll just move right along to our next agenda item, which has to do with the development of a consumer advisory board. So in the original DHE plan that Nashville developed, there are multiple references to some sort of community group that would be able to give input on services received, stigma experienced through primary research and with priority populations. And in the conversations that the ethics committee has been having, it's become more and more clear that this is something that's a priority and something that we need to do sooner rather than later. And so what we wanted to talk with you all about today is whether there are a lot of consumer groups out there already of people living with HIV who are active and happy to give their feedback on things. And so the question is really, should we just lean on one of those groups that already exists, or should we develop a group specifically for the EHE plan that can give input on the various projects that we are taking on? Any thoughts? I mean, one example would be the community advisory board. And maybe we could even lean on different groups for different things. The community advisory board has particular experience in reviewing research protocols and consent forms and things like that. I know that there are other groups associated with Ryan White that might fit the bill. Any ideas?
Claire, I wanted to jump in just real quick. Of course, I have no problem with the community the group, but it's like the question of fairness, I guess. It's yes, there are a lot of community groups out there, but if we're trying to be more inclusive, would it be not easier to try to recruit folks in? So it's not like we can let the other community groups know that we're trying to do this, and if their members, because sometimes what happens is if we choose a group, then suddenly some of the others may go, why were they involved? You know, that sort of thing. So I hate to pull human nature here, but unfortunately sometimes that does come to play, you know. So maybe some invitations to all the groups to like bring in representatives, or something anybody wants to consider.
So Regina, I'm sorry, I had a little bit of trouble hearing you, but I think you're suggesting that in the interest of radical inclusion, we might want to look outside the box a little more. Am I getting that right?
No, nothing like that. It's like, if you are going to have kind of like a community advisory group, sometimes leaning on an existing group creates, let's just say, ruffles a few feathers, you know, like why one group was chosen over another, you know? So
I see, okay.
Yeah, so what I'm just saying is like we send invitations to all the groups that are out there, and say like we're looking for members, so if who wants to be part of that, then they can look volunteer members who could take part in this. So you're being inclusive to all the groups without necessarily being, you know, like very selective to just one.
That makes sense.
So can I interject and just ask if everyone who's not talking, if you could please mute yourselves, because we're getting a lot of feedback and it's hard to hear. Thank you.
So I guess one thing we need to do if we're going to take that tack is actually take stock of all the different groups there are out there that that we might want to include. Another question I have is, do we want this to be exclusively people living with HIV? Do we want to include people who are on PrEP or anyone else? I don't really know what the best route is.
I know. Oh, sorry.
It's all right. I just wanted to ask, do you have a list of the groups that you had thought might fit? And I would also, I think I would second what Rajiv was saying in terms of how indeed then we would go about trying to choose the group. Maybe it's important for us to have a little sense of maybe a profile of some sort that we might want to guide us in our thinking, such that we would make sure of the representation being as broad-based as possible, and if any sense of it being more or less reflective of one group versus another, it probably should, to the degree possible, reflect those who are a part of priority populations and people perhaps most disproportionately impacted.
So we don't have a current list of what groups we were thinking of reaching out to. I won't claim to know what all of them are either. I think that's something we'll need the council's help with as well.
We could reach out to the leaders of our ASOs and CVOs and ask them about their psychosocial groups or any community advisory board that they may already have existing. And I don't think it should be something that's set in concrete. It's like, as we learn of new groups, let it be known that we can keep bringing people on. And also, you said something about just people living with HIV and people on PrEP. I think those would be two important, but should be kind of separate groups, because there's some crossover, but there's a lot of independent conversations that would need to happen amongst those two different groups.
So maybe it's more a matter of what the project is that they're sort of consulting on.
I think so.
So right now what I'm hearing is take stock of the various community groups that might be willing to participate, invite anybody from those groups that might want to participate, and maybe not having a consistent body for each project, but reaching out to groups based on the project and the need and the demographic that we're looking for. Does that seem to everyone?
And I think it would be really important not to just put out like a big, when we go out and ask, I think we should have a specific ask before we approach the community, so that they even have an idea of what they're getting into. And like you said, it would help facilitate even people who this issue affects, directly. They might want to speak up on one issue more than another. So if we kind of have a timeline or some kind of organization as to how we want to go about these different points, but be sure that we go to the community with specific asks.
Yeah, that's a great point. All right, I think we have somewhat of a plan. Does anybody else have thoughts they want to share or want to go in a different direction?
I just wanted to jump in. I was just taking notes as everybody was speaking. And I think it's also like, as all of us are like members of the, or represent leadership in various areas and are well known in the community, if we know of people that we think potentially can be involved, who may not necessarily, like who may not have been involved in the past, or I mean, I'm kind of like, I'm having a word jumble right now, but I mean, it's like using our like circle of contacts, and I guess like reaching out to them to see if like they would be willing to be part of this, So it's not just like groups, but also like people that we know that we could potentially bring in.
Sure, to engage people that might not necessarily currently be an existing group. Yeah.
Yeah.
All right, anything else before we move on? I will pass it back to you then, Dr. Bullock.
All right. Thanks, Claire. Can you hear me?
Yep.
Okay, always got to check and make sure I'm not on mute. So our next point of discussion is just what is going to kind of center around what's going to be our communication strategy for the council. We've got a few little pointers we want to talk about, but as I'm talking through this, I just want to make sure that I'm going to pose 2 questions, and then as I talk through this, just kind of think about those in that context. I actually do have these at the bottom, but I think just it'll give you a little bit of clarity around what we're trying to ask. So the 2 questions that we really want to talk about and begin the discussion on are, one, what are going to be our communication challenges or opportunities that we all should be aware of as we get out into the community and talk about what we're doing. And then number 2, the thoughts on the role of the council in our strategy communication. So I think what this council does challenge us to do, it's not just about what our individual organizations are doing, it's what we're doing collaboratively together across different organizations, different agencies, whether they be public, private, about what we are doing and how we're working together to actually achieve the goals of the council. Most of us and a lot of us do work in public health and social type organizations. So we don't always just remotely just go out there and say, hey, we're doing this. It just kind of is an understood of what we do. This is what we do. This is how we do it. And don't necessarily want to use this as an opportunity to say, hey, we're doing a great job, but we want to make sure people know what we're doing and understand what we're doing. And, us as the council is kind of our role to lead what that strategic communication looks like, or at least what that implementation looks like. And I think it does take on quite a few different, paths, depending on where we are in the communication with new initiatives, whether that be early, whether that be middle of it or late. I think it depends on whether or not that's our own council goal, whether that's our own implementation, or how many partners it involves. I think we can work strategically with those partners and at least partnering with them to help with that, help facilitate that communication, whether that starts within their organization and then branching out for more globally. I also think it also depends on for certain projects, we may even have to communicate with policymakers, people that are doing the funding. So lots and lots of different pieces that would go into this, lots of different parameters. And I think what we want to start doing is just kind of looking at what that framework looks like, kind of from a global perspective from the council, and start the discussion with us about what we think that looks like. We've got a couple things that are ways we can communicate, but I think I want to just hear from everybody a little bit about your thoughts surrounding that, what you think that looks like, how some of those are best facilitated. And this is just starting very globally. I think we can maybe break it down into projects, early, what that looks like, projects with partner organizations, and then what our expectation, at least individually, and then take that as a grouping as the council and what that expectation would look like as we branch out. So I'll give everybody kind of an opportunity just to kind of throw your thoughts out there. This is an early discussion. It's not the end all be all discussion. So we do want to start it and at least get some insight into your vision of what that may look like.
So one thing I don't see here is anything about developing a website. And I know that's something we've talked about, but being the millennial that I am, that's normally where I go to find information. I Google something and hope to find a website. And it may not be the flashiest way to get information out there, but it is something we can have that's sort of an up-to-date repository of what we're up to and who the contact people are for various things.
I do think that's how most people communicate nowadays. It's electronic, it's easy, it's quick. You can get it at 1 o'clock in the morning or 7 o'clock in the day. So, it's something that's easily updatable and reaches a wide number of people. So definitely. And I didn't put the list, I didn't kind of go through the list with you guys because I wanted to have everybody toss it out, but that definitely was not on the list. Thank you.
I would just increase a little bit more. Is like, like what, and I guess it's not a question, but how much of a social media exposure do we want for the group? It's like, do we want to be just like banner or banner ads on websites, or should we then look at Twitter or Instagram or I say Facebook as well, even though some of our target or priority populations are not have moved on from Facebook, let's put it that way. So I guess it's like the question I have is like, how much of a social media presence do we want?
Thank you, Rajiv. Anybody else? So I guess would you guys really want to start as we start this plan, start on more of a little communication with us as a council, and then as we start implementing initiatives, kind of disseminate that communication plan down and adapt it as appropriate for each different initiative?
Sorry, Dr. Bullock, could you repeat that? I'm sorry, I didn't catch that. There was a little bit of disturbance on my side.
Sorry. So I guess for everybody that's on, would you say that we would start more with our communication plan more as a global communication from a wider council perspective, and then as we begin to develop our initiatives and formulate what that plan looks like, kind of tailor our communication plans downstream to those?
I think that sounds good. I think it's worth talking about the other suggestions that Julie had, though.
Absolutely.
And I don't know if it's something we want to do, but
I think we can. I'll just go ahead and toss those out, and what Julie did have these on there. And like I said, this is kind of the start, and we will have Julie, I can't remember her name exactly, that was going to come and join us, but wasn't able to join us for this meeting as it related to our communications. But some of the other ways that we can look to communicate that were on the list were panels, symposiums, conference presentations, op-eds, interviews with local media, policy briefs, town hall meetings, and newsletters. And then what that engagement of individuals would be amongst each one of those. Who would those be? Who do you foresee those being? And how we would engage them to actually be the representatives for those items.
So if y'all don't mind, I can jump in here just for a second to give a little context on the thinking of just in terms of, just things that I'm thinking about, asks for the council members that are going to be coming down the pike, particularly in your organizations that you're leading, and your peer groups. We're going to be asking you to communicate the change management that comes with different aspects of what we're trying to implement. the example that comes to mind is the project that we're working on around trauma-informed care and cultural humility, and implementing that, in every provider organization in Nashville. Big picture vision. But we know that is it's not just receiving a training and then you're done. We know that doesn't actually create change. You need policies within your organizations to say, we're a welcoming organization. This is what means. This is how we hold ourselves accountable. And change at that level is within an organization. That's creating a new way of doing things sometimes, and that's along, the spectrum from executive leadership down to frontline staff. There's going to be different levels of readiness to kind of embrace that type of change, and so that's one level of communication that we're thinking about for this council. But then on a completely other end of the spectrum, globally communicating to the community around the science of HIV. So this group, you're the experts in this work and what we're doing and what's worked and what hasn't and what we need to do to move this forward. So even on the panel that Dr. Kelly was able to be on for the health department during Pride Week, we were talking, and sorry, Dr. Mavitt as well, we were talking big picture about, PrEP and PrEP implementation, but then we got a question from the community, well, what is PrEP? And just how do we get these big messages out to the community? And sometimes it's a big campaign, but we know we're not going to be able to find money for every big campaign. So these are kind of more of those, how do we just start to make the messages of the science exist everywhere? And there's a lot of different ways to get those into the community, and it would be based on the priorities of the council. Where do we need to start? U equals U is another big communication ask, and there are campaigns, and maybe that's the best way to do it. But it's also, spreading the word more of a grassroots fashion. And then, so the other idea is just, we know that there are some priorities that were in the EHE plan, like HIV modernization. But when that was put into our 2x2 for the equity work group, it was high impact, but low feasibility. And so the goal there is not to just lose sight of that, but it's to increase the feasibility of that. And, the way to do that is to increase public will, public buy-in. The fact that these laws even exist is one level. The community probably isn't aware of that at large, but then how do we start to change how the community is thinking? So that's the public level, but then, legislators, we have to communicate on a whole, different level. And so developing those communication strategies and, really wanting to know, just even from the priorities of the council, where you all think we should start. Sorry, I feel like I just talked a really long time, but.
Julie, when it comes to HIV modernization, there is, I don't know if you're aware, there's the new group. It's an HIV modernization movement group led by Doreen Morell and Robin Deering-Learing out of Memphis. But they are actually, Daryl has almost completed the website. We got to look at it last Friday. It is amazing. He's broken it down about what the law is, how it impacts communities, all kinds of things. So that would be a place to start. We're also on the group's also working on starting an education program for legislators and prosecuting attorneys to go in and talk to them about the effects of these laws on different communities and how they're having a negative impact, and also on people wanting to be tested and things like that. But yeah, I can give you more information and get you in contact with that group.
That would be great. Thank you, Brady.
You know, as I'm listening, I think that we're on point in terms of the ways in which we have identified uh, the kinds of avenues that we want to pursue in order to make sure we have effective information dissemination. But one of the things that I have increasingly come to appreciate about social media is that social media brings with it very often all of the baggage that's a part of a larger social picture when you paint it of communities. For instance, within social media, there are issues of class, there are issues of culture, you know, there are issues that kind of fit the whole socioeconomic spectrum in terms of the, you know, the differences that can be there. It's kind of the, it's also the fact that although there are those who have been able to speak, I think, to the way in which there's still a significant divide in terms of access to various forms of media. I think that it's just something for us to be sensitive to, because the science is the science. And I think there are ways in which we all, at various points, find ourselves struggling to wrap our minds completely around what we're hearing and fully understand the significance of the way in which the science is very often, you know, conveyed. But I want to suggest that in many instances, we are trying to reach depths within the community that require a level of translation that we ought to make sure we prioritize as something that we want to address. Because I do think that's still the case that the drivers of this disease can be very often identified in ways that are directly related to these kinds of socioeconomic factors. And if we don't figure out how to speak to, you know, I usually, you know, think the language of grassroots gets to be overused and really not fully understood at some points. But I think there is a strata, that there is a part of the community that we want to bring along. And we also want to make sure that it's developed in a way that allows us to take maximum advantage of persons who might be thought of as being the trusted voices in various communities, where people go for the information. So I would suggest, and I'm trying to work on a project right now around the COVID-19 issue in terms of communication. And I think it's just a point of awareness. Did I hear you say earlier that there was someone who was going to come and share with us some particular insights they had in terms of this whole question of mobilizing a social media initiative? Was that a part of what I heard earlier? And that person was not able maybe to be a part at this point. Is that right, Julie?
Not particularly around that, but I mean, if that's something you think the council would benefit from, we could look at that for our next agenda.
Okay. Well, I think, yes. I mean, I'm not sure everyone necessarily agrees with that, but I'm just giving you the benefit of my personal observation in a lot of things that I've run into, especially of late, in terms of trying to communicate effectively with people, things that we would think of very often. I guess I'm especially focused on the COVID-19 issue right now, but I'm amazed by the way in which I think the messages that seemingly are the most important for people to hear are about as simplistic as you can get. We start talking about distancing and you know, even things as fundamental as hand washing and the like. But even with that, it's amazing to me, and wearing the mask. I mean, it's just amazing to me how it would seem that that's about as simple as you can get. But the fact is, we do know that the effective implementation of it is waning in a way that, you know, we need to try to figure out how to address. And I think there's some similar kind of carryover to that in the way in which we're still dealing with HIV. So anyway.
It's always a pleasure to hear Reverend Sanders speak. You know, it's while you were talking, Reverend, essentially, I got something that just popped up on my email and it just caught my eye. So it just said, it's time to share the light. Now, that was the subject on the blast email. And I was like, it just caught my eye real quick. And I clicked on it, and it's something very, very simple. It's Hope Shines in Tennessee, and it's the lighting the way to end cancer. And this is from the American Cancer Society. Essentially, at some point, they've put it on, is like you should either take a flashlight or a candle or something on some sources of light, and to put it out and share on Facebook. I mean, it's something as simple as that. How many lives have been touched by cancer? It's the same thing with HIV also, I think. You know, it's like you see something as simple as that. You're building a community in itself, you know? You have a disparate group. It didn't matter whether it was like all the demographics that we see. This disease has touched so many people, and something as simple as that can like raise awareness. And I think, as Reverend Sanders had mentioned, something simple, you know, something that really is easy for people to do and be part of, you know. And I think we have to be mindful, because when we do try to start getting complicated, that's when we start dealing with complexities, dealing with issues. You know, it's like let's keep the messaging simple. You know, I mean, there is a big effect when you say, you know, it's the economy, stupid. You know, it's like that was powerful. And it's very, very simple. And if we do just put out undetectable equals, undetectable equals untransmissible, boom. Or again, there are people much, much smarter than I am, but I think it's something like we can do is, like, if we are going to do some sort of media thing, put something out there that's like eye-catching, and it's like, oh, okay, what is this about? You know, at least that's what I've seen previously, and to show my brilliance. During the hepatitis A outbreak, we were having a discussion with the within the health department with various heads of the department on how we message it. And as a joke, I turned to the person next to me and I said, you know, we should have a poster that says, if you got the shits, come for the shots, you know? And I thought it was just one of those 5-second, everybody chuckles and then we move on. Odd as it may sound, that was actually what we used for the people to get Hep A vaccines, you know? Unfortunately, we couldn't use shit, pardon my language, but, you know, they had the emoji of that, as well as an emoji of the needle. So it was something as simple as that, just trying to get into people's, I guess, everyday conversation or vocabulary. Sorry for rambling on and on and on.
Can I just say, going along the lines of keeping the message simple, I had the opportunity to and the privilege of sitting in the rooms when the CDC was working on their messaging and came out with that U equals U, it's effectively no risk. And all of the talk that went behind and the research and focus groups and choosing one specific word. I just want to emphasize the importance of what Dr. Sanders said and being able to translate it to communities, because at the end of the day, we have to look at reality in life. And when we go out and we take risk assessment every day on things, whether we get behind a wheel or we take a bus or we go for a walk. And if we have to, and it's the duplicity in both COVID-19 and HIV, getting people to buy in that this is serious and important, but at the same time, not creating and building into the fear and creating more stigma and people not wanting to talk about it. But there's that duplicity that also exists between the two, is how we get different communities to buy in to the risk assessment, that, why it's important to do these things, such as washing your hands and wearing a mask and staying socially distant, while at the same time not creating a whole bunch of extra panic and fear within these same communities.
I'm just thinking about U equals U. I mean, it is about as simple as you can make an issue that's actually very complicated. And when I sort of expand it out and think about somebody who's living in Nashville and doesn't know really anything about HIV except what they heard in 1995, they don't know what undetectable means. They may not have any idea that there are medications out there that can suppress the virus so fully that you can't even detect it. So just thinking, going back to Reverend Sanders' point, we have to really come to people where they are and make sure that we're delivering the message in a way that people are prepared to receive it. And I know that budgets are tight, but it just seems like if we wanted to put together a really good campaign for any of these issues that we've been talking about, we just kind of need professionals to help us with it. I don't know if it's possible, but.
And I also would say, even with the U equals U campaign, one of the issues with us coming out with U equals U was that it was too simple. And even though, so it's that counterbalance, but even though we wanted to come out with something simple and hope that it would continue, make conversations go, and people could see the benefit of, of adherence and staying, engaged in care, and using it as a message to make treatment universal for everyone and accessible to everyone. So there's also that there's sometimes too simple is we got pushed back on that too. So
yeah. Brad, let me just say, I do want to be clear about this though, and that is, I think the simplicity issue is significant, but it's also then who ends up being, how we cultivate the strategy around the messengers. That's a big part of it, because I've learned that, for instance, in clergy circles, I can say a lot of things that people just allow to go in one ear and out the other because they have an expectation of who I am saying it. I think for a lot of us have been involved in the HIV issue for many, many years. There's a way in which what I find myself trying to do all the time is the issue is getting people who are, respected, trusted voices, or people that, can really capture the attention of as broad a cross section of people as possible, and make sure that we are not just saying it simply. That's kind of what I meant when I was saying, I don't think you can get it much more simple. The way in which we're talking about the effective strategies around this COVID issue. I don't think it's much more simple in terms of the science, in terms of U equals U. But the fact is, you still run into that kind of reference that it's still somebody else's issue. And so the issue, what we're looking for is to get a level of ownership across the board that is not driven by any of the traditional, kinds of stereotypes or anything else that people bring to the table around the issue. So I think that's our challenge. But I do want to just keep saying also that this whole business, there's a lot of research these days about how you measure digital sufficiency in terms of social media and communication. because evidently the issue of a digital divide is still much bigger than we sometimes think it is. Because many people who have, for instance, the devices do not use them in the way in which I could help but think a minute ago when we were making a reference to the whole issue of where we get our information. Sometimes there are a lot of people who have the technological equipment. They have the technical equipment, but that's not the way to use it. You know, it's not where you necessarily use it as you might be there to use it if you're more of a, if you think in more academic terms, let me put it like that, you know. I use it in the way in which I would, Google just about anything, or even if I always say, I think Google has made the dictionary obsolete for me in life because if I want to make sure I can do my spell checks on anything all the time. But that's a very different kind of use of that little device than a vast, segment of the community that has those devices don't necessarily use it for that kind of way in terms of information. So I'm just suggesting some challenges that we might want to try to take on and focus on. And it might require hearing some voices of people other than the ones that we might quickly turn to because we know they have some appreciation for the issue or ownership in the issue. We might be trying to just drill down a little deeper and get feedback that might help us because we know a lot. We've got a lot of information and we've got a lot of tools at our disposal. The issue is being how do we get people to use the tools and how do we get people to, to buy in, to the cause, which has come to be for us. It's a cause. It's a movement.
Well, Reverend Sanders,
yeah.
If I could interject here, I think it's really about timing. Right now, because we're in the pandemic and people are at home and they've been fixated on televisions, on social media and all of that the Black Lives Matter movement that we have going on right now it has happened before, but people were distracted with doing other things. But because they have the time now and it's fixated on the CNNs and MSNBC and all of those, they've taken advantage of it, and that's how everything went viral with Black Lives Matter. I think we need to take the same approach and use this time to get this information out there and have people focus in on the pandemic that we're dealing with or the epidemic that we're dealing with HIV and AIDS. And we can't lose ground on that. And maybe it's not the first pandemic or the second pandemic to racism, but maybe it's the third, and maybe we need to focus on, something to that. So I agree with the keeping it simple. We got to shut it down, and maybe we just get out there and send that message, and we utilize this time right now in order to, while we have people's undivided attention.
Yes. Councilwoman Hurt, let me tell you something that I find interesting to what you just said. I'm amazed by how often we do not talk about these issues that are looming so large before us. We don't talk about them in ways in which there are clear intersections. I mean, there are clear intersections in terms of talking about Black Lives Matter and talking about the ways in which, the reality of the virus, the reality of HIV. If there's something that happens if you get focus on a single issue, kind of politic or movement, when really a part of what's driving the issues and the complexity of the issues is that they all do intersect at a certain point. So there's a reason why the priority populations end up being very often a part of the same way in which you define the people who move to the streets in terms of Black Lives Matter. And the other thing about it in terms of the Black Lives Matter is how clearly it is an issue that can be presented in a way that transcends some of the barriers that we always think are there. For instance, I mean, it is significant that when those young ladies got 10,000 people in the streets, that the admix of that group that was in the streets was the ability to kind of, you know, sound a chord that resonated with people in a way that really got beyond a lot. You know, so I'm just saying, all these things to me have points of intersection.
Absolutely.
And
Well,
the more
to your point,
yeah.
there has been quite a bit of request for a mural to go on the street that says Black Lives Matter. And I heard from Nancy Van Rees from the LGBTQ caucus that if and when we get this mural painted on a street, then maybe one of the letters could be painted in rainbow, which I think would be an excellent way to, because there's no way that we can talk about Black Lives Matter without including those people who are LGBTQ+. So I think taking advantage and leveraging every opportunity is exactly what it is that we have to do. And we don't have to reinvent the wheel, or it doesn't have to start with us. We jump on it while it's wet, while it's rolling, and make sure that we get in there what it is that we need to send that same message.
Yeah. Oh, I agree.
This is a great conversation, and I hate to sort of move to the next topic, but we are a little bit short on time. But to the points that you all were both making, I've been a little bit disappointed not to see HIV more of a conversation in the Black Lives Matter movement, because there are so many intersections. And I'm going to quote some research that I can't tell you where it came from, but I read somewhere recently that providers are less likely to tell their Black patients about U equals U and less likely to offer them PrEP. And I mean, that's just one or two small issues that we're looking at here, but they're really indicative of huge issues when it comes to health disparities and the way that people of color are treated in healthcare. And I think you're right that the time is right for us to do more messaging around that. And I think we lost Julie, unfortunately. It looked like maybe she had some internet issues.
Her internet connection got bad. She lost video and then she dropped out entirely.
Okay, well, we have one more sort of major thing that we do want to make sure we have a few minutes to discuss here before we get to announcements and wrap up. So the last time we met, we talked about sort of lumping HIV testing in with COVID testing and how that might be an opportunity. However, we've had some meetings outside of the advisory council at this point to discuss that. And logistically, it was just sort of a nightmare to make that happen, especially in the 3 metro testing centers. So the goal, just to remind everybody, is for 90% of Nashvillians to know their status and to develop some strategies for achieving that. And we want to increase accessibility and acceptability of testing. And these numbers aren't published anywhere, but Julie got them pretty much directly from the source. So rapid HIV testing in the second quarter of 2019 compared to second quarter of 2020, non-clinical testing numbers are down about 50%, and clinical testing is down around 30%, which is not necessarily surprising given what's going on, but still disappointing and something that we want to keep an eye on. So we just wanted to take a few minutes to talk about collaborative strategies to continue HIV testing in Nashville, the risk versus reward of in-person testing, and how we can reach our target population to improve the likelihood of maintaining a less than 1% positivity rate. And also, if anybody wants to talk more about this after the meeting, we'll probably have non-council related meetings to discuss how we can do a better job of increasing HIV testing, since it is one of our major goals. But for now, just want to hear any of your strategies for HIV testing, and whether it is something we should be prioritizing right now, given the dangers of seeing people in person if it's not necessary.
Fair. And I need the political voices to help me with this. But I think we do need to return to the strategy of how you turn the issue of universal, testing policies. That could be a part of the medical care, health care, kind of across the board. We've got a tough job ahead in the fact, obviously what's happening with COVID is people are dying. And, since the antiretrovirals and, the developments in terms of the treatments that we have for HIV, there is a way in which that language of chronic progressive disease has, stumbled into the marketplace, even in a way that has somehow lifted the some of the mass fear, hysteria, whatever that was a part of what was driving. But the main thing that was driving the issue before was, there were just the mortality rates. There were just so many deaths. But now, obviously, this COVID virus has captured the attention of folks, and again, it's driven by fear and anxiety and the like. So my point is this: the universal testing. I don't know how we need to try to push that issue. If we could probably show some way in which it translated into a tremendous cost saving in terms of medical care, because it seems that very often you get responses on the political, front when somehow you can say it's economically more effective, the like. But we still need to consider getting back to the point where there's routine testing for HIV, and at least where it's offered, even if you don't come up with a mandate that requires it. I'm not sure we want to raise the banner in the way it was raised before, because it seemingly was driven by the hysteria around the lives that would be lost. So I would just say we might need to talk about how that becomes a political agenda. I don't know if that's within the purview of what we're allowed to advance, but at least we might be able to suggest the way in which it could be important.
Brian, do you want to say something?
If it's okay, I think one of the things that animated some of the discussion, the initial discussion around doing the testing at the COVID assessment centers, is that was potentially a safe place where folks are congregating, and it doesn't have sort of a, if you will, a bias in the distribution of folks who show up. One of the things that might be worth exploring is whether or not we should really think about, and let me back up. That's also what's driven testing at festivals, at Gay Pride and Black Gay Pride, and at gay bars. And it's where do you meet people where they are to provide testing access and make it as easy and accessible and convenient as we can. If the bars are closed and if the festivals are postponed, and if the doing testing alongside COVID assessment sites is infeasible, I think one thing that we might really want to think to explore is how do we promote at-home testing, and how do we think about the feasibility of that? So just to come back to the COVID assessment center, we may not want to distribute at-home kits at the COVID assessment center, but we could. We could distribute the kits at the Department of Human Services or wherever people go for some sort of face-to-face interaction, the DMV or something where you might have an unbiased distribution, or you might find people that you're otherwise going to miss. It's probably a much more exact way of saying it. So I'm still trying to understand the mechanics and logistics and costs of at-home tests, but I think that might be worth exploring with Metro Public Health in the state.
Brian, I'm glad you said that. As just a community advocate, one of the top questions I've been getting through Facebook Messenger and Instagram since April has been about home tests. I know that there are, and I'd love to, I have no idea what the numbers are, but I do know that some ASOs in town have been sending out home testing kits. But I would love to know what those numbers are, but if there's any way that we could help promote that, because apparently from the amount of questions that I'm getting about it, that information is not getting out into the community.
Yeah, if I can just piggyback with one more comment, and thank you for saying that. One of the things that we're seeing a lot more of is just is at-home treatment for STIs, and because you can, on some level, be able to diagnose without having to bring someone in clinic for a test. The downside to that is if you treat without a test, and it's just a balancing of risks, whether getting some sort of test or diagnostic test is appropriate, is outweighs the COVID risk. But for everybody that we don't test in clinic and we treat at home, we lose the opportunity to test them for HIV. And if we had tests that we could mail to them and say, while you're taking your antibiotic, why don't you also do this? I think that would be huge, especially given the financial impact of the pandemic. We're not in a position to just sort of pony up, buy the test and send them out and process them when they come back. And I think we would be willing to do the distribution if those tests are provided.
I just wanted to jump in and pretty much agree with both Brady and Brian. It's actually, I'm just going to tangent away a little bit, but to bring back to the home testing. So this was a conversation I had with the director of our HIV STD prevention and surveillance program this morning here at Metro. And this was kind of like one of the conversations we had was about the testing and how we were not going to where the population, we weren't going out to the population. We were expecting the population to come to us, and how that has not been very feasible. And one of the things that we were saying is like, we do have at least one type of avenue through the health department. And that is our disease intervention specialists, as well as our early intervention service specialists. What these folks are doing is they're going out, especially when they're doing the risk assessment and partner contact tracing for people with who have been diagnosed with STIs. And sometimes this might be your only time that you're going to get with that particular client. And they may take the medications, but they may not come back for any sort of like follow-up. But this is an opportunity where essentially you could do a rapid test with this particular population who are who've been diagnosed with the STIs, and you need to do this surveillance for public health purposes. At the same time, you're getting that opportunity to not only educate that that person, as well as get them tested. And the thing is, with the rapid test, potentially by the time you're done with your interview, you can have the result and, oh, you do have HIV, you do have services for you. And we're trying to start up the rapid initiation of treatments here in Nashville as a pilot program, with hopefully being expanded later on. But that would be kind of like the next step. You know, it's like, hey, we have this, we can refer you to so-and-so who can meet with you and then start with the treatment. Or if they're found to be negative, it's potentially like risk reduction. We can say, hey, listen, this was negative this time, but there's a higher risk in the future. So would you be interested in a PrEP? So, I mean, it's one of the things that we were kind of like discussing. And the big problem we had was who was going to pay for the test, because unfortunately here at the health department, they were not, the state was not willing to pay for both the rapid as well as the blood-based test. And for those who you're wondering why is that, the CDC and then the state prefer blood tests because of like there's a small difference in statistical differences. The rapid was 99.7 effective, while the blood-based was 99.9. And you're like thinking, what does that matter in the that 0.2%? They're looking at it in like large populations. So essentially, when you have like 100,000 or 1 million people, that there's going to be a discrepancy. While in just for one person, that may not seem like a big thing. So they were more, since the blood was more accurate, they are willing to pay for the blood-based test, which you have to wait for some time. And that also brings out, you need somebody who is properly trained for it. You have to have a sterile environment like a lab. You need to be able to store these specimens. You have to be able to transport it. Then the lab has to do the testing. Then the results have to be sent back. There has to be a system in place for that. So that creates a whole multiple layers of really getting in your own way for solving the problem, when potentially you had the person in front of you, you could educate them, you could test them right then and there, you could get the results right then and there, as well as potentially moving them in the next phase, whether treatment or prevention, future prevention. So this is something I think like we, that as to the political component, that may be something that we may want to think about, like advising those in leadership, saying, hey, instead of doing it this way, why not we go down this road where we might be, where the folks that are trying to take care of the patients are where the patients are rather than the other way around. And I think that's something that we need to consider as well as the home kits, because the only reason why I worry about home kits in a small way are those people who are unstably housed. Where do we send? Where do we send it? You know, and sometimes that, and if we can't send it by mail, then what do we do about, you know, like, do we put depot area places where they can potentially get the test? So we have to consider that as far as the home tests. And that's what I wanted to say. Thank you.
So Rajiv has thought about this a lot, naturally. I do think this is something that we probably just need to continue having outside meetings about, because it is such a major goal and such an important part of this plan, and sort of really a baseline goal. So if you are interested in participating in future meetings to keep discussing the testing issue, send, I guess, Julie an email, and she can add you to any future meetings that we have on the topic. And I'm, in the interest of time, going to go ahead and ask Dr. Bullock to take us out here.
Absolutely. We've had quite a bit of robust discussion today. So thanks to everybody on the call. I think we have quite a bit of follow-up for next meeting, but do appreciate everybody's time today. Just one announcement here. Just want to remind everybody that the Center for Nonprofit Management is offering a discount on all their community and collective impact related workshops, including the Intro to Collective Impact workshops. Julie has all the additional information if you should need it, and we'll actually add it into the minutes. And then our next meeting is September 17th from 2:30 to 4. And currently still location to be decided depending on where we're at in a couple months. So if nobody has anything else, just want to say thank you again. Do appreciate all of your involvement and all your participation, and stay safe and stay well. And thanks to Julie for all of her hard work in kind of organizing the WebEx, the agenda. It's been quite a challenge, but we really do appreciate it.
Thanks, everybody.
Thanks, y'all.
Everyone.
Everybody be safe.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information about this and other programs, visit nashville.gov.